Hello and welcome everybody to today's e-seminar, which is organized by the ERA. We are very happy to have with us today three real experts in the field of bone biopsy and bone diagnostics. First of all, we have our speaker, Professor Pieter Evenepoel, who is currently the chief of the UROD, the European Renal Osteodystrophy Working Group, which is part of the CKD-MBD working group of the ERA. Professor Evenepoel is also a professor of nephrology at the University of Leuven and a senior consultant at the University Hospital of Leuven. We have also two panelists. We have Professor Marie-Helene Lafage Proust from Lyon, France. She is leading the research group on bone biopsies there, a long-term expert in the field of bone diagnostics and especially focus on renal osteodystrophy. And we have Professor Pablo Urena from Paris, France, who is also a many years expert in the field of bone diagnostics or even a wider CKD-MBD diagnostics, spanning from clinical and biochemical diagnostic questions to research on treatment options. So I welcome everybody to this very interesting topic, bone biopsies, when and how. Bone biopsy has been around for many years and has been an instrument that has helped us to understand renal osteodystrophy and the wider area of CKD-MBD. But as a clinical tool, it has always played a minor role. And I'm very happy that Pieter Evenepoel today will give us a good overview of this method and its potential as a clinical diagnostic. So please, Pieter, may I welcome you with your presentation.
Thank you, Mathias, for the nice introduction. I tried to open my presentation. I hope you can see it. Yeah? If this is the case, I can proceed. Mathias, can you confirm you see the presentation? Okay, perfect. Then yes, we can move on. So the title that was given to me is Bone Biopsy, When and How, and I'm very grateful to the ERA to put it on the agenda because I think that bone biopsy is a neglected tool in the complete diagnostic armamentarium that we have in the diagnosis of bone disease in patients with CKD. So in the forthcoming 30 minutes, and I hope I can move my slides. And these are my disclosures. So in the forthcoming 30 minutes, I will have first a short introduction to the field, then discuss with you when to perform a bone biopsy, and then how we could perform a bone biopsy. So starting with a short introduction and talking about the skeleton, we should know that a skeleton is a collection of about 213 bones of all shapes and sizes and serving a variety of functions. Most importantly, it provides structural support, but also it permits movement and locomotion. It protects vital internal organs and functions. It provides maintenance of mineral homeostasis and acid-base balance. It provides the environment for hematopoiesis, and also it acts as an endocrine organ. So the skeleton is much more than just being, let's say, supporting the structures. I mean, it's much more than that. It's composed mainly of mineral, 50 to 70%, but also organic matrix, 20 to 40%, a little bit of water and lipid. But also it's a living organ, meaning it's also containing cells. And the most well-known cells, the cells of the bone, include osteoblasts, which are the bone-forming cells. We have also the osteoclasts, as you can see on this graph, which are the bone resorption cells. And finally, we have osteocytes, which are the most numerous cells in the bone, accounting for more than 80% of the cells of the bone. And these are in fact the headquarters of the bone. They're sensing, they do mechanical sensation, and then they talk to the other cells and they tell them what they should do, building bone or breaking bone off. The coordinated actions of osteoblasts, osteocytes, and osteoclasts occur with within two biological contexts. On the one hand, there's bone modeling, and this is the process that shapes skeletal elements and ensures the acquisition of the appropriate bone morphology and mass during growth. And this is uncoupled. Whereas bone remodeling is the process by which bone is renewed to maintain bone strength and mineral homeostasis during adult life. And this is coupled, meaning that at the same time, there will be first bone resorption and then bone formation. You should remember that all these processes, bone modeling and bone remodeling, are very slow processes. They do take time. So in order to see changes in the bone biology, in the bone morphology, and what's going on in the bone histomorphology, this is something which takes time. So it's not something that you do bone biopsy every week to see changes to occur. I mean, it's a slow evolving process. And so the minimum time between two bone biopsies is something like 1 year to be able to show any difference or any change. So we all know that CKD does affect bone biology. And this is already known since the 19th century. And the terminology of renal osteodystrophy was put forward in 1942. And the big change was then in 2006 when the KDIGO said, okay, really appreciated that bone cannot be seen in isolation. There's a close link, for example, to vascular biology and also to lab changes in the blood. And so they come up with the concept of the CKD-MBD, so chronic kidney disease, mineral and bone disorder. And we all know that all the components of this syndrome, they contribute alone or in aggregate to the increased burden of cardiovascular disease that we see in our patients, also the increased mortality, and last but not least, also the increased burden of fractures. And just to illustrate this, looking at data coming from the TOPS registry, and it is looking at the incidence of hip fractures in dialysis patients as compared to general population, you can see that whatever the age is, both in females and males, the incidence of hip fractures is several-fold higher in dialysis patients. So it's said nowadays that in dialysis patients, the incidence is fourfold as high as in age and gender-matched population. So really, we see a lot of patients with fractures in our dialysis wards. And then, of course, the monitoring and the assessing of bone health is a very important task that we have as nephrologists taking care of patients with CKD. And in assessing bone strength, and if we discuss bone strength, this means bone quantity and quality, we have several tools at hand. These include imaging tools like Dexa scans, for example, but also biomarkers can be used. Also, nowadays, there's a new technique called microindentation, which is some kind of functional testing also to evaluate bone strength. And finally, last but not least, there is histology and histomorphology to assess bone health in our patients. So knowing which of these tools to be used in your patient, you should know both the strengths and the limitations of all these techniques. And so starting, for example, with biomarkers, we know they're very easy to take. I mean, the blood sampling is very easy to perform. And we also can imagine that they reflect changes in bone turnover very rapidly and also do reflect what's going on in the skeleton as a whole. But of course, they have also some limitations. For example, the lack of tissue specificity. Some of them do have an important circadian rhythm. Some of them are retained in kidney failure, so that should be acknowledged. Most of them are characterized by a substantial analytical and biological variability. If we compare them with the gold standard, which is still bone biopsy, they all show a high negative predictive value. So they're very good in excluding a certain bone condition, but in confirming a certain bone condition, for example, low or high bone turnover, their performance is much poorer. So they have a rather low positive predictive value, especially for bone turnover. And last but not least, you also give little or no information on the mineralization status or the volume of the bone. Another tool which has gained popularity certainly since the publication of the KDIGO update in 2017 is a Dexa Scan. This is widely available in most countries and it nicely associates with fracture risk. But we should also know the limitations of Dexa. This doesn't give you any information on turnover, neither on mineralization. So in fact, it does not distinguish among types of renal osteodystrophy. And also it cannot give you any differentiation between cortical and trabecular bone. This can be done by another imaging technique, which is the PQCT or the high resolution PQCT, which is able to distinguish between cortical and trabecular bone, but these machines are very expensive and not widely available. So this is more like a research tool than something which is used in clinical practice. Finally, we have bone biopsy, and still this is considered the gold standard for the diagnosis of bone disease, also in patients with kidney disease, because it's inform you on the turnover, the mineralization, and the volume of the bone. And also it gives you information on non-D microarchitecture. So it's the gold standard. But again, it has also its drawbacks, limitations. It's still an invasive technique. It's laborious to perform a bone biopsies. Also, the reading of the bone biopsy is not easy. There is specific expertise needed for reading this bone biopsy. And also, I mean, what you do is you perform an analysis of a bone on a specific site, mostly the ilium, the ilial bone. And of course, you could question the external validity. Is this telling you something what's going on in other bones, in the appendicular bones, for example? So that's something also still a question mark. But again, for analyzing turnover and mineralization, bone biopsy remains the gold standard. But it has limitations, and because of these limitations, bone biopsies, that we all know, is something which is rarely performed in clinical practice. So according to this survey that we performed some years ago among nephrologists with a special interest in bone, you can see that only something like 20% of the nephrologists that took part in this survey, they told that they perform sometimes a bone biopsy for clinical purposes. So this really remains an orphan diagnostic procedure. Despite this is an orphan diagnostic procedure because of all these hurdles that we have and all the constraints that there are, and the most important ones is that still most nephrologists do believe that this is a painful sampling procedure. But another important hurdle, or let's say constraint, is the fact that the pathological expertise is vanishing rapidly across Europe, and there's not many labs that are able to do formal bone histomorphometry. And these are important constraints contributing to the fact that there is no many nephrologists nowadays still perform a bone biopsy. But still, if you ask these nephrologists whether they think there is really a place for a bone biopsy and what are the indications then to perform a bone biopsy, you will find that for many indications there is consensus. They agree upon that for that reason we should be able to perform a bone biopsy. And the most important, again, according to this survey, was to exclude low bone turnover disease prior to initiating anti-resorptive drugs, and also to confirm iron or heavy metal overload in a patient when there was some suspicion as this patient was indeed having iron or heavy metal overload. So these are the most important indications that were, let's say, given by the people, by the nephrologists that filled in the survey. What was in the position of the KDIGO concerning the indication of a bone biopsy? Well, it's stated by the in the recommendation that in patients with CKD grade 3A to grade 5D, it's reasonable to perform a bone biopsy if knowledge of the type of renal osteodystrophy will impact treatment decisions. So there's really an important aspect that you should only do a bone biopsy when it will change your treatment, that it will, I mean, have an impact on what kind of treatment you will propose to the patient. So, and also when we as a center looked and try to implement this recommendation in practice, we do believe that you should consider bone biopsy before beginning osteoporosis therapy in a patient suspect for mineralization defect. I mean, the only way to really confirm mineralization defects is by bone biopsy. And suspicion can be there if you see a patient with a low phosphate, hypophosphatemia, prolonged metabolic acidosis, low vitamin D levels for a while. This is a patient that probably could have a mineralization defect. Or when you live in an area where there's still use of aluminium as a phosphate binder, there's a lot of contamination of the dialysis water with heavy metals, including aluminium. So there also there was a suspicion of aluminium and or probably iron overload. And this is also a formal indication to perform a bone biopsy. Certainly when you consider osteoporosis therapy because the patient is presenting with a frailty fracture. Also, before beginning osteoporosis therapy in a patient suspect of having low bone turnover, because in this patient, of course, the most common treatment, which is an anti-disruptive agent, would not make sense. I mean, it will not help these patients as the low bone, as the turnover at baseline is already low. Also, you could consider to do bone biopsy in patients before starting PTH suppressive therapy. And again, when it's a definitive therapy like surgery, then you would like to be sure, is this really high bone turnover? And in such patient, to confirm high bone turnover disease, a bone biopsy could have a place. Also, when you face a patient with an unexplained hypercalcemia, often following transplantation, the only way to be sure it's not as a consequence of too high PTH, but could be the consequence of something else, then the only way to be sure about it is to perform a bone biopsy. So these are the main reasons we in Leuven nowadays perform bone biopsies in a clinical setting. Of course, always it's a shared decision. You should inform the patient on what could be achieved with a bone biopsy, what are the, let's say, potential complications and so on. And then together with the patient, you can decide whether you go for it or you don't do it. So once you make the decision, yes, we do, you have to prepare your patient. And then we're coming to the next, let's say, part of my presentation, how we perform a bone biopsy. And in order to get most out of it, the bone biopsy, it's important that you label the biopsy. And labeling means that you will be able to perform dynamic bone histomorphy. It will give you a very important information on bone formation rate. And we label the patient by giving the patient 2 cycles of antibiotics, being tetracycline, because these tetracyclines can be visualized using fluorescent microscopy. And one of the specific characteristics of these antibiotics is that they will be deposited during mineralization. So if you give 2 cycles of this antibiotic with a time span in between, there will be 2 lines of deposition visible on the fluorescence microscopy. And again, knowing the time interval between the administration of the label, this allows us to calculate the bone formation rate and also the mineral position rate. So it gives you very important information. In order to get most out of it, labeling is something that certainly should be considered. Most of these antibiotics are well tolerated. They can give some GI, let's say, problems. Some of the patients are allergic, but it's important that you give these antibiotics, let's say, apart from phosphate binders and antacids. So you should stop them during the administration of these antibiotics in order to increase the bioavailability. With regard to anticoagulants, like low molecular weight heparins, DOACs, and so on, I mean, these are on hold prior to the procedure. But anticoagulants, at least when you use the smaller needles, and I come back on this in a moment, there is no need to stop them for the procedure. So in the procedure, you can make use of two different types of needles, graphene needles. I mean, these are the older needles being used until, let's say, a decade ago, almost everywhere. These were the Bordier needles. These are non-disposable graphines. They need to be sharpened in between procedures to, again, sharpen the needle. But nowadays, there is a move to using the disposable graphines, like the Yamshidi needles. These needles do have a smaller inner diameter. This one-time use, so it's disposable. So that's something which certainly make it more easy, that you don't have to sterilize the needle, you don't have to sharpen the needle regularly. So it's something which is certainly nowadays make it more easy to perform a bone biopsy everywhere. And this is again gaining popularity amongst nephrologists performing bone biopsies nowadays. During the survey at that time in 2017, about half of the nephrologists were using the big needles, the Bordier needles, and half were using the Yamshidi type needles. Using of an electric drill, it's something which is used by some nephrologists, but certainly not the majority. And I personally have no experience with an electrical drill. The bone biopsy can be performed in an outpatient setting. You can see how the table is prepared. We need some kind of anesthesia. We need the needle. We have gloves. We have sterile to proceed with the bone biopsy with this sterile material. And then we have the patient being in a supine position, and we can perform bone biopsy in two ways. There's on the one hand, the horizontal approach, where you, of course, as the name says, it's a horizontally approach to the ileum. And we have also the vertical approach. And this is a slide coming from Mathias Haarhaus. He is performing in his unit the vertical approach. In Leuven, we're using the horizontal approach. Both are, comparable in a way that they both will yield sufficient material. A difference between both techniques is that with this vertical approach, you will have only one cortex, the outer cortex, and that you have a long piece of cancellous bone, whereas in the transiliac approach, you're normally when you have a nice, let's say, cylinder, you will have both the outer and the inner cortex in the same sample, which could be of interest. Before performing the bone biopsy, you need to anesthetize the periost. And at least what we do in Leuven is we only anesthetize the outer external periost. We don't do anesthetize the inner periost. I do know other nephrologists performing both the outer and the inner anesthesia, but at least in my experience, I think that patients could have more pain of the anesthesia than from the needle advancing through the bone. So we don't do it in Leuven, we only anesthetize at the external periost. Then you have to gently provide pressure with the needle. And again, when you use the smaller disposable graphines, there's no way that you have to use a trocar, that you need to surgical instruments to make the hole bigger. It's very small incision, and then you advance the needle directly to the bone, and then you start with rotating the needle, gentle pressure, avoid major physical forces in order not to break the bone, and then you advance slowly but steadily. Once you arrived at the inner periost, and this will, the moment the patient will sense a different kind of pain, it will be an arching pain, then it's time to stop. You can a little bit change the angle of the needle to break the cylinder, and then by making clockwise and anti-clockwise rotation movements, you then retrieve the needle together with the bone cylinder within it. This is the blind technique, so no CT-assisted technique, which is also applied by some nephrologists. This is a slide from a study from Fabrice McQuay in Quebec. He is asking the radiologist to perform the bone biopsy with a CT. And of course, with CT, you can exactly position the needle or the Bordier needle, trocar. So it's probably more, let's say, a secure way. Of course, it's make it more complicated, more invasive. You need more people, you need CT scan and so on. So this is a possibility, but certainly also you can do it in a blind way. And again, as I will tell you in a moment, the complication rate is very, very, very low. I would say that the procedure is rather easy, and so watch one, do one, and teach one. It's probably can be applied to this procedure. So I don't think it's really something that you need a lot of training about it. There's always a learning curve, but it's a very steep learning curve, at least in my impression. As you can see, we do it also with a little bit of sedation, midazolam sedation in an outpatient clinic where we monitor the blood pressure and the pulse. And we also monitor the oximetry. As you can see, I mean, this should be remembered. I mean, bone is a hard tissue, and to advance the needle through the cortex is really something which is I mean, it's not that easy, and so you need a little bit of force to bring the needle through the cortical bone. And you just remark the small drop of sweat. It's not because I'm stressed of doing this job, but just because it's such a strenuous and such a hard job to get the needle through the cortical bone. And also, see, at the same time, the patient, he is almost sleeping. So the discomfort for the patient is really minimal. And this is one of the misconceptions we still have about bone biopsy. And everyone is always starting laughing. Bone biopsy, you cannot do it. It's too invasive. But at least with the smaller MCD needles, with a nice preparation, anesthesia, some slight sedation, it's really something which is very well tolerated by the patients. You end up with a small incision, and then also because it's such a small incision, you can close it easily with some steady strips. In the case of a Jamshidi needle, when you use a bigger Bordier needle, you need some stitches to close the skin defect. Then, of course, you have to collect the bone biopsy material. We mostly take two samples, one for which is stored in ethanol, which is then for bone histomorphometry. Another one which is stored on a RNA and DNA stabilizing solution for molecular diagnostics. So we perform always two punctures in one patient. If you use the Bordier needle, which is of course a thicker needle with an inner diameter of 7 millimeters versus 3.7 millimeters, so this will yield you more tissue. And according to the experience of the Quebec people, they are able to split then the bone biopsy in different parts, also enabling them to send the bone material both for histomorphometry and for molecular diagnostics. Complication rate is very low, less than 1%, and also this is the experience we have in Leuven with more than 500 procedures performed over the last 10 years. Complication rate is a little bit higher for the horizontal approach as compared to the vertical approach. And of course, you will see more complications when you use a larger diameter trephine needle. Discomfort of the pain of the patient is acceptable. They experience some pain, but at least if you would ask them if it is severe, then most of them would say no. It's really, I mean, it's really very well tolerated, and the best proof of that patients do tolerate the procedure well is that we were able to do bone biopsies in a large cohort on a regular basis, so people are willing to come back for another bone biopsy, and that's the best proof that indeed the morbidity is really acceptable. It's sent to the lab, stored in ethanol, can stay on the bench for some days, so there's no hurry to send it up to the laboratory, and there it undergoes several steps of processing, sectioning, and so on, and then it's stained with different kind of stains, mostly the golden stain, but also we need the fluorescence microscopy for the tetracycline or the democloxylin stains. And then it's further assessed using some software to do a semi-automatic histomorphometric analysis. It's all time-consuming, laborious, and And so the turnaround for reading a bone biopsy is about 4 to 5 weeks until we have the result of the bone histomorphometry. Results can be both qualitative, so it can be a qualitative assessment that is performed in some labs, but other labs do the formal, complete quantitative assessment. So this is the formal bone histomorphometry according to a standardized nomenclature that had been published some years ago. So you can see a lot of parameters that have to be assessed, and then they are recalculated to what we call secondary indices of bone histomorphometry. So it's a lot of work to collect all these indices, and this then results in a report that was previously we used the nomenclature of osteoitis fibrosa to indicate very severe secondary hyperparathyroid bone disease, or mild hyperparathyroid bone disease, endodynamic bone, mixed uremic osteopathy, and osteomalacia. But this terminology was not that much saying to the nephrologist, and they didn't know exactly how to go on with this diagnosis. That was one of the reasons why some years ago it was decided to move on to what we call now the TMV classification, so according to turnover, mineralization, and volume, which is much easier to interpret by the referring nephrologist. So it's much more actionable than the former categorical classification in osteoitis, endemic bone, and so on. There are some challenges that we face. I mean, certainly the reproducibility of a bone biopsy is not well known, and certainly it's not good with regard to volume. So I would favor against using a bone biopsy to assess the bone volume. I think a Dexa scan is much more reproducible and much more informative. The second challenge is that it's a time-consuming procedure. So you have the labeling of the patient, which takes about 3 weeks. Then you have the assessment, which also takes several weeks. So in a world where we expect to have the results on the desk the next day, this is not happening with a bone biopsy. So it remains time-consuming. Also, something that needs to be solved is that if you would send the bone biopsy to the one or the other lab, different labs are using different cutoffs. So it could end then with different diagnoses in your patients, depending on to which lab you're sending this. And this is something that we are nowadays dealing with within UDOT, that we harmonize the normative ranges used for the diagnosis of the different categories, both of turnover, mineralization, and volume. Also, something people say probably it's too costly procedure. And I just give you the example what we do in Leuven, and I do acknowledge that it can be different in other sense in other countries, but it's about 1,000 euro, I would say, the cost of the whole procedure. So both the bone biopsy procedure itself, the labeling, the analysis, which is the most costly part of the whole, which is about 565 euros in Belgium. So it's costly, but again, when you compare this cost to costs of common therapeutics and just consider that you could avoid that your patient needs to be treated with Synacalcet because you exclude high bone turnover in your patient, you should know that 1 year of treatment with Synacalcet is about 4,300 euros. So this is really also very costly. So at the end, probably on a macroeconomical basis, a bone biopsy performing more bone biopsies would certainly not be bad. Another, and I think the most important challenge that we're facing is how to implement it. I mean, bone biopsy is very, it's dispersed across the country. Some centers are doing a bone biopsy, but you don't know how to approach these people, how to refer your patients. So what we need to do as a community, as a nephrology community with a special interest in bone, is to set up some kind of bone biopsy liaison services. And I do know that these kind of services do exist in some countries like France. So that is very important because then you offer, let's say, some kind of a trajectory to your nephrologist, what he can do in case he's facing a patient in whom he thinks or she thinks there should be bone biopsy performed. So a nephrologist is facing a problem regarding CKD-MBD. He will collect history and the medication of this patient. He will have a look at his lab parameters, certainly, again, looking at trends, very important, and also will collect some imaging. Based on this data, he will or she will try to come to a diagnosis. When this is not feasible, he could refer or could discuss with a nephrologist with a special expertise in bone what to do next. And if both of them decide, okay, we need a bone biopsy, patient could be referred to this nephrologist for a bone biopsy. He or she will do the bone biopsy. Bone biopsy will be sent to the pathology lab, will be processed, and the analysis, as said, takes some weeks. There will be a pathology report, could be integrated with the clinical report, and then sent back to the nephrologist in order that he or she can make a diagnosis or also can give it guidance for therapy. Also, it could be that some of these bone biopsies are discussed in a clinical pathological conference, multidisciplinary, which certainly makes sense for difficult cases. And this again can then guide the nephrologist in how to treat his patients or can help him to come to a final diagnosis. So this kind of bone biopsy liaison services is something that we need to develop, and they can be set up both regional, but also national, but even also European reference centers can be created in which, I mean, we can apply this algorithm. A glimpse in the future, I think we'll move to non-invasive procedures using smart refined needles. There will be more central reading because there is indeed a vanishing of the expertise, pathological expertise. Probably we will integrating machine learning tools in the diagnosis. Also, probably molecular diagnostics could help in making a diagnosis. The results in some cases will have to be discussed multidisciplinary, and then we'll create a report sent to the referral nephrologist. I think this will take me to my take-home messages. I do believe that the bone biopsy remains useful in the workup of bone fragility and complex mineral disturbances in patients with CKD, despite an expanding non-invasive diagnostic armamentarium. So we see improvements in bone turnover markers, we see improvements in bone imaging techniques, but for some of our patients still a bone biopsy will be needed to come to a final diagnosis and to guide the therapy. So I said while bone biomarkers perform well in excluding high and low bone turnover, a bone biopsy may still be required for definite confirmation of a diagnosis of high or low bone turnover prior to starting a specific therapy. We should emphasize that the procedural related morbidity of a bone biopsy nowadays is limited when we're using the disposable needles with an inner diameter less than 4 millimeters. And again, this yields sufficient material for a formal pathological diagnosis. I do believe with an anticipated incidence rate of 10 bone biopsies per million population, a bone biopsy may be categorized as an orphan procedure. And therefore, we need to install regional or national bone biopsy liaison services, which may facilitate the implementation of bone biopsies in clinical practice. I think this was my last slide. I will like to thank you for your attention, and I hope we have a lively discussion. Meanwhile, I all of you invite to join the 5th Europe Winter Meeting, which unfortunately is organized virtually, but still I think we have a very nice program, which this year is focusing on adenamic bone, whether it is a disease or not. So thank you all, and looking forward to the discussion.
Thank you very much, Pieter, for this excellent presentation and summary of current knowledge and use of bone biopsies. And thank you also for opening for many possible interesting questions. I would like to ask everybody to please use the Q&A function in the browser if you want to pose any questions to Pieter Evenepoel. And I also want to ask both of our panelists to discuss this presentation vividly, hopefully, and of course you can pose questions also to the panelists. And while we are waiting for the first questions, maybe we can start by asking or reading out the question that has been sent to us ahead of this lecture. You have already touched on this topic a little bit, but maybe you could expand the question. The question is, what is your opinion on drilling devices for bone biopsies? And this question maybe we can open for all participants in this panel.
Yeah, thank you, Mathias. Indeed, so drilling devices, I mean, if you go through literature, some of the, let's say, all the studies or all the surveys or all the registries that collect data on bone biopsy, they used a drilling device, which of course makes it more easy I mean, for accessing the bone, but it also makes it much more complex. I discussed this with the technical team within our hospital to also build some kind of in-house device that we could use together with the needles in order to get some kind of a mechanical drill to help us in advancing the bone, because as I said, bone is hard, and I can tell you with probably even more difficult with the smaller needles than with the big needles to keep the bone on the periost fixed is something which is it's tough, and then it's very hard. And I showed you let's see, the sweat drop on my head, but also I didn't show you my hands. I have a bone biopsy, hence with lots of blisters and fibrosis on my hand because of the procedure itself. So a drill could be something which could be of help, but it makes it more difficult and more, let's say, it makes the procedure more complex. And if you're working in a center who is performing, let's say, on a weekly basis, 2, 3, 4 bone biopsies, of course, that could be of help. But if you're doing only 10 bone biopsies a year, I wouldn't invest in such a machine. No, just using the trephine needles. I mean, they're a bit bigger than the needles used by the hematologists. So, and you know, hematologists do perform bone biopsies. I mean, for very, I mean, indications, a little monoclonal peak in the blood is sufficient to convince them to go on with a bone biopsy. So, I mean, this should not be one of the hurdles we face. I mean, and certainly the drill, I mean, will not make a difference. I do see more like a hurdle than that's something that can help us.
Thank you, Pieter. Yes, I think I agree with you in this point. And let me please ask our panelists, do you want to add anything? Has anybody any personal experience of using a drill?
No, I have no experience whatsoever with an electric drill. I think when you have learned how to perform a bone biopsy, even if it's sometimes tough, I don't think it's useful, because it's you need to train with this kind of device. So the ones who have been using are very happy with it, but I don't have any experience of that.
First of all, I would like to thank Pieter for this update, a very nice presentation. Congratulations, Pieter. And as Maria said, I have no experience with the drill. We have a use for a long time the trephine, Bordier trephine, which was very good. And Pieter, if you have a pain in your hands, use boxing gloves or something that protect your hands.
If you can buy some sterile ones, then please send me.
Excellent comment. Thank you, Pablo. I understand you're using them.
I'm going to keep teasing Pieter, because I have one question for him. Most of the fractures occurs in patients with osteopenia. They don't have osteoporosis. In patients with a CKD in dialysis, or no, 2/3 of the patients have osteopenia with a C-score greater than -1.5. I'm wondering whether the bone biopsy histology could improve or probably predict the patient. Sometimes renal osteodystrophy that is more associated with the risk of bone fracture. Can you comment on that? There is any study?
Yeah, certainly. I mean, of course, Pablo, we have to make a distinction for the bone biopsy as a clinical tool and a scientific tool. As a clinical tool for these patients, I don't believe there is a clear indication, at least not at this stage. But of course, I mean, we know all that most patients that present with fractures do not have osteoporosis in a sense that they have a T-score below -2.5, but as you said, do have osteopenia. But of course, because they present with a fracture, which is a proof of bone fragility, there's something going wrong with the bone. And so in order to understand the pathophysiology of bone fragility, I mean, of course, their bone biopsies could be of help. And there is, of course, within the osteoporosis world, you have some bone biopsy studies, but they're very limited. And this is also, I think this has come to some standstill because of the invasiveness of this procedure. And people were not willing to, I mean, undergo such a procedure because, of course, I mean, the therapeutic implications, at least at this stage, are very limited. So it's like a pet situation in chess. I mean, what to do next? I mean, it would be nice to have more bone biopsy data in these patients, but there's no one willing to do this because the direct benefit for the patient is limited. So I don't believe we'll have ever these kind of studies. But yeah, it's again, and this is also one of the aims of the UDOT initiative, which aims to build a repository of all bone biopsies being performed in patients for whatever reasons. And as I said, for the moment we are focusing on patients with CKD, but it's my dream, and I hope this is shared by the steering committee, that once we'll move to the osteoporosis world and also try to collect bone biopsies that have been collected over the years in patients with osteopenia, osteoporosis, patients with normal Dexa scores, but nevertheless a fracture. So, I mean, there's much to be learned about how a bone biopsy can help in unraveling the pathophysiology of bone fragility, for sure.
Yeah, but I fully agree with you that the bone biopsy indication is very limited in CKD patients, even in dialysis. And the other thing, if you look at some of the results shown on the last ASN by Maluka group, looking at the therapies like alendronate versus denosumab in high bone disease, and there is no benefits using the bone biopsy. They didn't show anything important. And the other thing, in low bone turnover, using teriparatide also showed some benefits on bone mass and vascular calcification. It's very, I mean, I still believe it's very limited, the indication in clinical practice.
Yeah. Yeah, that's also what I mentioned in my reading of the KDIGO guideline is really also more limited than the indications which were raised by the nephrologist we surveyed in 2017. And again, I see that, I mean, we have performed a lot of bone biopsies in the field of, I mean, when we were doing some kind of natural history a study for science. But I mean, the number of bone biopsies really to be performed for the clear clinical indication is limited. Okay, I do believe there's still more cases that we should do than at the moment, but it never will become a procedure which is, let's say, which is part of routine follow-up. I mean, never will it be as such. But there is still some kind of a gap. I mean, there's certainly many patients in whom we started therapy, which after a while seems not to work well, and probably in these patients beforehand we had to do a bone biopsy to know what's going on. Osteomalacia is one of these could be one of the underlying diseases. A low bone turnover state could be something which could be the cause. So for some of them, a bone biopsy should be done. again, I mean, but to convince the referral nephrologist is really hard. I mean, because it's still in their mind that the bone biopsy is such a very tough and painful procedure, and this is something that we need to get out of the mind of nephrologists.
Thank you.
Maybe I'll make a comment. We have been experiencing this multidisciplinary approach for the last 2 or 3 years in the south of France over several cities like Bordeaux, Limoges, Poitiers, Lyon, Clermont-Ferrand, and Saint-Étienne, where I have my rheumatology department in the hospital. And I can say that the patients that we discuss the case of are very complex patients. You know, they have sometimes hypophosphatemia, they are hypocalcemic, they had a gastrectomy history. I mean, it's not the basic dialysis patient that who is healthy, I mean, brackets healthy, but they are very complicated patients. Sometimes they have been transplanted twice or 3 times. So they are very complicated patients. And over this maybe 200 patients or 250 patients that we discussed over the last years, maybe with the indication of the biopsy was something like for 15 or 20 patients. So again, it is an orphan procedure. But when we do perform a biopsy, it is highly informative, and eventually we make the diagnosis of a mineralization defect or find an adynamic bone disease while we thought it was a normal bone remodeling or so and so and so forth. So I think, again, it's not a general indication for many and basic patients, but with very complicated patients with many fractures, I think it is the best tool to eventually make the right diagnosis and may design the best therapeutic strategy for the patient. So this is the first comment I would make. The second one would be what you mentioned, Pieter, about the Fabrice Marquet paper when they used and they asked the radiologist to perform the biopsy. And these have been done in some cities in France. And I think it's a good opportunity to increase the practicing the bone biopsy. For nephrology department, we will never have the expertise or the willing to do or the time to do that kind of procedure, while the radiologists are widely used to perform biopsies in the bones for diagnosis purposes for tumors or whatsoever. So I think it's a good idea to ask to a radiologist who would be willing to do that, because it will be maybe easier for the nephrologist to access this kind of procedure, while it is almost impossible to implement this kind of procedure in their own department.
Yeah, I completely agree. I'm a little bit skeptical because it makes it more complex. But again, if you make good appointments with the radiologist, it's certainly a good solution. Yeah.
Otherwise, if there are no other question, I am surprised that you performed the bone biopsy with the YAMCHD3 fine, keeping the anti-aggregant treatment.
Yeah.
You didn't have any problems with the keeping the anti-aggregant treatment?
We had I said we have more than 500 bone biopsies, and there's one patient with a hematoma, but I even don't recall whether she was on anti-aggregantia at that moment. I mean, no, because nowadays also we performed in many cases at the same time of a kidney biopsy, because it was in the frame of a protocol, and for that reason also nowadays we don't stop anymore for transplant kidney biopsy. We don't stop the aspirin anymore. So no, it's no problem. But again, I mean, also the hematologist, I mean, the needle is a little bit thicker than the ones used by the hematologist, and they don't even stop the anticoagulant. I mean, and they do biopsies with platelets of 20,000 and even less. So I don't believe that there is risk of complications. You can easily, I mean, there's local compression that we always give for a while following the bone biopsy, and really hematoma, it's very, very, very uncommon. No.
Okay, Pieter, you need to precise if you stop the anticoagulation or anti-aggregation.
Anticoagulation we stop. Anticoagulation we still stop.
AVK you stop. Okay.
Yeah, so the DOACs and the warfarin we stop, but the antiaggregants, the
antiaggregant.
aspirin, we just go on as of now. We don't stop. No.
I want to comment that shortly. So for the vertical approach, you don't even need to stop the warfarin. You can do it in any setting. So we are having some questions. One question: if you have no possibility to perform a bone biopsy in a patient on dialysis with high risk of fracture and no apparent evidence of low remodeling, will you start anti-resorptives?
Short question, yes. Well, I mean, this was one of the big changes between the KDIGO 2009 and 2017 that as a group, we decided that, I mean, if you're not able to perform a bone biopsy, this may not be the reason that you should not proceed with treatment if you deem this is necessary. So, and if you have a case with a frailty or the fragility fracture, and if you have biochemical indices that argue against low bone turnover, please proceed with therapy. If you have, of course, if you have, as said, bone turnover markers nowadays, they can help you in excluding a condition. So a high normal alkaline of a normal high normal alkaline phosphatase in the absence of other bone biomarkers would argue against a low bone turnover and would make you very comfortable in initiating an anti-resorptive agent. Follow the alkaline phosphatase or follow other bone turnover markers when there is no decline in these bone turnover markers following initiation of an anti-resorptive agent. You may again question whether this was indeed the good choice. But did something go wrong then? Not really, no. So my short answer is yes.
And Pieter, to comment again with this question, do you have any proof that the anti-resorptive therapy is worsening bone histology or in the long-term treatment? There is new data showing the toxicity of these drugs.
Do you mean in the context of CKD patients? Or?
Yes, yes, yeah. In the context of CKD.
And what kind of, I mean, there is, of course, I mean, you know, Pablo, there is no much evidence. We don't have these large studies being performed in CKD patients. There have been some smaller studies being performed over the last years, looking at both at vascular safety.
We have a bona fide in bone histology with calcimimetics.
Yeah, that's of course.
We have a vitamin D.
But we have also recently from the Izeri with alendronate and with denosumab again. But of course, they all were very, I mean, reassuring with regard to vascular safety, also skeletal safety. I mean, there's no reason why this should be harming these patients. There is no reason why. I mean, there's animal data that showed, if I'm correct, that the impact on the bone is not different depending on the kidney function. I mean, and also, I mean, if you start with a low bone turnover, it's not said that you will end up with even lower bone turnover than a patient with a normal bone turnover giving the anti-resorptive agent. So there's a lot of, yeah, I mean, of course. And again, I would certainly invite everyone to join the Europe meeting, because we'll have a very nice pro-con debate on anti-resorptives in patients. And again, the topic of endemic bone is something that makes us very frightening. And hopefully following this meeting, it will be more clear than it is at the moment.
Thank you.
Maybe I could add a question to the question. I cannot decide whether I'm going to give a treatment on such a scarce information. When we decide to give a patient anti-resorptive treatment, we need the biological history over the last year or the last 6 months. We need the age. We need whether he's registered on the transplantation list. We need to know whether how many falls he has done during the last year, and so on and so forth. So you cannot give any treatment on such a scarce information. You have to collect all the possible information that will provide you not the certainty, but the idea that what you are doing is the best for the patient, either not treating or treating. But for instance, if she or he is young and has had steroid therapy for the kidney disease that induced his CKD, and that he has fall because he has a neurological condition, then we can seriously discuss about the giving anti-resorptive strategy. But if she or he is 82-year-old, has of course maybe fractured the wrist, and has a very poor life prognosis, maybe I will not treat the patient. So I think this is very important to understand, that you cannot give a treatment on such a scarce information.
Marjolein, I cannot more agree about it, but my thing was to just make some kind of
I know.
Yeah.
I fully agree too.
Yes, I do agree too, but on one point I would maybe disagree, and this is the 82-year-old lady that fractured her wrist, because this is the typical patient with osteoporotic fractures, and these patients do, from a clinical point of view, have a lot of suffering. And my personal experience is that in patients with fractures, especially in older patients, anti-resorptives have a symptomatic effect. So they relieve the patients from pain. I'm also thinking of patients with vertebral fractures who can often suffer a lot from these fractures, and have a good effect of anti-resorptives. And maybe I'm not so worried about
no, don't make me say what I didn't say, Mathias. I was saying, if she has she's 82 and has a fracture and has a poor life expectancy, maybe she has I don't know, carcinoma, whatever, then just let it go. I mean, at 82 with a 1 year life expectancy, I won't bother to give a treatment. That's the reason it's a little bit caricatural, but sometimes we have this kind of discussion as well. So of course, 82 and fracture and she's autonomous despite she's on hemodialysis, maybe we can discuss the treatment. Of course, I agree.
Well, thank you very much, Marie-Helene. So, and I think it would also be interesting to turn the question around and ask, why should we take a bone biopsy before giving treatment? So the question was, should you give treatment without a bone biopsy? But Pieter, you have already mentioned that in your lecture. When or what are we really afraid of when thinking of this invasive procedure before giving osteoporosis treatment? Would you like to comment on this question, Pieter?
Yeah, I do understand there is some concern. So I mean, there is low bone turnover. I mean, is associated with poor outcomes, and we can, I mean, have a whole discussion again. This will be in extenso being addressed during the UDIT meeting next week. But of course, I mean, if the point is if low bone turnover per se is causing or is increasing the risk of bone fracture, or it's just the disease which is causing the low bone turnover, could be diabetes, inflammation, malnutrition, which is causing the increased fracture risk. So that's one of the misconceptions, is because we all have seen an association between low bone turnover and poor outcomes, and we think it's poor bone turnover per se, which is the cause, which is certainly not proven. It could be more like the disease causing the low bone turnover, which is the culprit. So that's an important thing that we need to keep in mind. On the other side, of course, low bone turnover in an environment where the kidneys cannot regulate, for example, calcium levels to within a very tight limits. So the buffering by the kidneys is lost. So if you there have a patient where you also lose the buffering by the bone, then of course you then at risk of facing hypercalcemia. And of course, hypercalcemia is one of the drivers of vascular calcification. So on both sides, there is could be some reasons why to say yes or no, low bone turnover is something that we should fear. But again, this is a topic on its own that needs to be addressed in a different topic, in different talk, I would suggest.
Thank you very much, Pieter. And this was a good invitation to attend the next EUROT meeting. As I cannot see any more questions posed, I would like to sum up this very nice e-seminar. Thank you, first of all, to Pieter, but also to our panelists for very vivid discussions. And I hope that all attendees got some insight into the procedure and maybe even new thoughts about how to use the bone biopsy as a clinical tool. I would also like to remind all ERA members that the current e-seminar gives you 1 European credit for the CME. And I would also like to announce the next e-seminar by a working group, which is on sleep disorders, breathing in CKD, risk and remedies, and it's scheduled on January the 25th. It's organized by the Eureka M working group. So thank you to everybody for this nice seminar, and I wish you all a pleasant evening.